Welcome to The Explainer. Today, we're diving into the fascinating, complex, and, let's be honest, often totally misunderstood reality of migraines in adults. If you've ever had one, you know firsthand it is so much more than just a bad headache. So today we're going to unpack the actual science behind what's happening in the brain, how doctors act as detectives to categorize and diagnose it, and the rapidly evolving arsenal of treatments we have to fight back. So let's just get right into it. Chances are you or someone you know is intimately familiar with this condition. To really grasp the massive scale of this issue, we have to look at the numbers. Migraine is a highly disabling condition that affects 12 to 15% of the general population. Think about that for a second. It's one of the most common complaints neurologists see, and the prevalence actually peaks between the ages of 30 and 39, affecting women a lot more frequently than men. Now, here's where things get really interesting, and it kind of breaks down our preconceived notions. When you hear migraine, you probably immediately picture flashing lights or weird visual disturbances, right? Well, a staggering 75% of cases are actually migraines without aura. Only about 25% of people experience those focal neurological symptoms before or during their attacks. All right, so here is our roadmap for today's explainer. We're going to see why this is more than a headache, explore the different types, look at how we diagnose the condition, and then dive into both first-line and advanced treatment options. Let's go. Starting off with Section 1, more than a headache. We really need to look at what actually happens in the brain, because a migraine is a deeply intricate neurological event. A typical attack progresses through 4 distinct and honestly exhausting phases. First up is the prodrome, acting as an early warning sign hours or even days before the pain hits. We're talking extreme fatigue, neck pain, or even unexplained food cravings. Then comes the aura, if the patient has that subtype, bringing visual or sensory disturbances for up to an hour. After that, the throbbing headache itself, which can last anywhere from 4 to 72 agonizing hours, often with severe nausea and a total intolerance to light and sound. And finally, the postdrome. The pain might be gone, but patients are left with a migraine hangover, feeling utterly drained for up to a full day. Smack in the middle of this intense cycle, a lot of patients experience something wild called cutaneous allodynia. This is a brilliant example of central sensitization. Basically, it's a sensory shift where normally completely harmless touches, like brushing your hair, shaving, or even just resting your head on a soft pillow, suddenly become incredibly painful. The brain's pain pathways just become so hyper-responsive that normal, non-painful signals get completely misinterpreted as severe pain. Okay, moving right into Section 2, the types of migraine, because categorizing this disorder properly is absolutely crucial for figuring out how it manifests across different people. Beyond just the typical with or without aura labels, there are some incredibly rare subtypes out there that literally mimic other severe neurological emergencies. For example, hemiplegic migraine causes temporary motor weakness on one side of the body. It basically looks just like a stroke. Then there's retinal migraine, which involves temporary blindness in one eye. We also see migraine with brainstem aura, causing vertigo or decreased consciousness, and vestibular migraine, known for intense episodes of vertigo. And of course, we can't forget chronic migraine, where patients are suffering from headaches on 15 or more days out of the month. So that brings us to Section 3. How do doctors actually diagnose this condition with so many variables? It's time for some detective work. It really is a clinical detective process, and doctors rely heavily on a structured checklist called the ICH-D3 criteria. To diagnose a migraine without aura, they're looking for a history of attacks lasting between 4 and 72 hours. From there, the headache has to have at least 2 specific characteristics. Maybe it's on just one side of the head, has a pulsating quality, is moderate to severe, or gets worse with routine physical activity. But pain alone isn't enough. It has to be paired with at least one associated symptom, like nausea and vomiting, or that severe sensitivity to light and sound we mentioned earlier. Now, this naturally leads to a super common question, and one that understandably causes a ton of anxiety. If a clinical diagnosis is basically a checklist, does that mean you need an expensive MRI or CT scan just to be absolutely sure it's just a migraine? The really reassuring reality here is no. Neuroimaging is usually completely unnecessary. However, that detective work we just talked about is meant to uncover specific red flags. If a doctor finds an unexplained abnormality on a neurological exam, or if the headache has a terrifying, abrupt thunderclap onset, then yes, they'll order a scan. Same goes for things like having your very first migraine after the age of 50. But without those red flags, a clinical diagnosis is incredibly reliable all on its own. All right, Section 4, first-line migraine treatments. Once the diagnosis is locked in safely, we shift from detective to healer and start building an arsenal to stop these attacks in their tracks. The treatment game plan follows a very logical, stepped approach. For mild attacks, we start with the basics, simple, accessible analgesics like NSAIDs or acetaminophen. But if we're dealing with a moderate to severe attack, we escalate to specific migraine medications called triptans, a lot of times combined with an NSAID for a bigger punch. And this is key. If someone has severe nausea or vomiting, where taking a pill is just not going to work, the strategy completely shifts to non-oral routes, like nasal sprays, injections, or IV antiemetics. Let's zoom in on triptans for a second, because they really are the gold standard for moderate to severe attacks. They go straight to the source, targeting the trigeminovascular system in the brain. They block those pain transmission pathways right in the brainstem and stop the release of inflammatory neuropeptides. But they do something else too. They promote vasoconstriction, which means they actually narrow the blood vessels in your brain. Which brings us to our final section, advanced treatment options. What happens when first line just isn't enough? Or what if a patient has cardiovascular risks that make taking those blood vessel narrowing triptans super dangerous? This is where modern medicine is just so cool. Because triptans constrict blood vessels, they are totally contraindicated for anyone with a history of stroke or ischemic heart disease. It's just too risky. So for those folks, we have advanced options like CGRP antagonists, often called GPANs, and a drug named lasmidantan. These are absolute game changers. They provide powerful, targeted pain relief, but they completely lack that vasoconstrictor activity, making them a much safer alternative. And what about those truly severe, stubborn attacks that end up in the emergency room? The healer's arsenal gets even bigger. Doctors can use intravenous antiemetics like prochlorperazine or metoclopramide to knock out pain and nausea. They might bring out intravenous dihydroergotamine or sodium valproate. There's even growing evidence for non-invasive neuromodulation devices. These actually use electrical or magnetic currents to directly disrupt the brain's pain signaling. Science fiction, right? But, and this is a massive but, there is a very crucial caveat to all of this. Patients have to carefully limit how often they take these acute medications, usually to fewer than 10 days a month. If they take them too often, they risk a cruel, cruel irony: medication overuse headaches. The very pills meant to stop the pain actually start causing daily, chronic rebound migraines. It's a really delicate balancing act. Which leaves us with one final, pretty provocative thought. We've mapped the phases, we know the nerve pathways, and we've built drugs to block the exact molecular signals of pain. So, considering these incredible recent leaps forward, how long is it going to be until we can shut down the migraine cycle permanently? Are we moving from just managing the attacks to truly curing the condition? Thank you so much for joining me for this explainer. I really hope it helps clear up the wild, complex world of migraines.